Thank you for that introduction. And to reiterate, myself, Dr. Paramita Majumdar, and greetings from Guru Nanak Institute of Dental Sciences and Research, Kolkata, on behalf of all the faculty members of the department at the institute. So I would request that you let me know if there is a disturbance in the audio, or if there is a drag, or if the slides are not moving, because I will have the WhatsApp pinned, the group pinned, so that I will get to know if there is a problem.
Okay, ma'am. We'll inform you on WhatsApp.
Yes, and another thing is, if the slides do not move, do let me inform, or do let me know. So whatever we do and whatever we are, there is always a history behind it. And I would like to dedicate this particular talk, which has been so cleverly and so nicely initiated by Dr. Chikoy Wang and his team at Buddha Institute of Dental Sciences and Hospital. And my tribute to my teachers is a way of acknowledging the fact that we are nothing but what we are taught out of wisdom. So here, I have learned from many people, but I have put the pictures of the examiners for my MDS examination, my internals and my external examiners. I would request the students just to pay attention to what is being said instead of trying to record the screenshots, click the pictures, etc., because I believe it is going to be recorded. Just listen to what is being said. All of you are very much prepared because your MDS examinations are knocking at the door. It is just an attempt to make a revision class and give some clinical tips so that during the examination, the process is much more acceptable and it is easily handled by the students. So I have titled this particular presentation as Practical Insights into Mastering the Precision Restoration. So kindly emphasize on these words. It is a practical insight. Though there will be applications of this particular procedure that we call as the precision restoration, there will be a little bit of theory as well, because without the theoretical background, it's very difficult to understand the practicals. And whenever you're doing the practicals, you'll be able to understand the actual implication the words make in the theory. Prepare a material which has the best of the properties of all the metals added together. Now, when we say noble metal, which is usually the type of restoration that is asked during the examination, we mean the metals like gold, silver, platinum, palladium, ruthenium, rhodium, iridium, ruthenium, and osmium. So these are the metals that resist oxidation, tarnish, and corrosion during heating, casting, or soldering, and when used intraorally. Gold and platinum are the best examples. Rest of the materials are used in varying concentrations to alter the properties. Base metal alloys are the elements that make up the alloy that do not resist tarnish and corrosion, and they are not thus noble. Now, precious metal, platinum group, gold and silver, and they refer to the economic value of the particular material instead of the technical or the dental parlance. Now, the ceramics that can be used either for inlays or onlays range from feldspathic porcelain, lucite reinforced porcelain, alumina reinforced glass ceramics, lithium disilicate, lithium aluminosilicate, dense sintered zirconia, sintered alumina, or glass infiltrated zirconia or alumina. So, ceramic restorations are not new. From the 1700s, the porcelain teeth were used for dentures, and later, in the latter part of 1800s, ceramics were tried as the inlay restorations or the extracoronal restorations, and it has undergone a sea change because the properties have changed. We have desired for more and more translucency is required, strength is required, and the stability is also required. The fit will be required, and so many processing techniques are also available for ceramics. Thus, at this juncture, we have the glass infiltrated zirconia or alumina ceramics that may be used. Coming to indirect composites, they came into being because we wanted a solution to the huge polymerization shrinkage that was happening, the marginal integrity that was failing, the discoloration that was happening, the sensitivity that was happening, and the number of steps that were involved, the technique sensitivity of the direct composites. Now, indirect composites came into being because we wanted to overcome all these difficulties with the direct composite reasons. So now we have so many options, and mostly all these systems use some kind of additional curing mechanism, either light and heat or light, heat, vacuum. So many systems have been named here. They can be a combination of direct, indirect, or direct, indirect, both. Whatever the student chooses depending on the infrastructure available in the particular institute or department, and as the teachers direct the students to do. So these are the material options that should be available and the knowledge that should be there with the students when they are appearing for the examination, because the syllabus and the examination mandates that it can be bold or it can be an aesthetic inlay. Now, as I said, a little bit of theory will be there, because unless and until we understand the real meaning of the words, it is very difficult to put everything into practice. So coming to the term inlay, the term itself has the meaning inside it. So something which is put inside is an inlay. So it is a fixed intracoronal restoration made outside of a tooth to correspond to the form of the prepared cavity which is luted into the tooth. If it is a class 2 inlay, it involves the occlusal and proximal surfaces of a posterior tooth and may cap one or more but not all of the cusps. Now, coming to this particular definition, sometimes it becomes very confusing. Inlay is to be made clear that it is inside, so it is an intracoronal restoration. Some books do not have the extracoronal part or the cusp capping part included. Some books say that they can cap all but one. So they cannot cap all the cusps. So that is an inlay. If it is involved in the proximal surface, it becomes a class 2 inlay. And if it is capping, it is class 2 inlay with cusp capping. Now, the classical example that I always want to give is the beautiful monument, the wonder, which is Taj Mahal. If you look at the flowers and the patterns that is there on the marble walls, these are inlaid surfaces or inlaid patterns. So inlay can be a class 1 inlay, class 2 inlay, class 3 inlay, pin inlay. It can be even a class 5 inlay. The essence is when it is class 2 and when the contact and contour is of utmost importance, that is why and that is where the stability and the clinical performance of the inlay becomes most important. That is why when we discuss, it is mostly class 2 inlays instead of the other classifications that are existing for the tooth preparations. So now we know the definition. We will go into few indications and advantages, disadvantages as we move on, but we must understand the difference between inlay and another particular term which is there, which is onlay. Now, onlay is a restoration that will restore one or more cusps and adjoining occlusal surface or the entire occlusal surface retained by mechanical or adhesive means. In a class 2 onlay, the proximal surface will be involved and it can cap all the surface, all the cusps, but the entire tooth is not covered. If the entire tooth is covered, that becomes an extracoronal restoration solely, which is a crown. So this is the difference between inlay, onlay, and a full crown. Inlay is inside, it can be proximal, then it becomes a class 2 inlay. It may cap cusps, but not all the cusps. Onlay is something which is overlaid above. It can have a proximal extension, but it will not cover the entire extracoronal surface, as against a crown which is covering the entire surface, which is extracoronal. Now coming to the materials which may be used for fabrication of inlays. Now this is a classical chart which is present there. Up to the class 5, it is there in Marzu. Composite resin is of course an addition. Now this classification is many a times asked because when we are talking about gold alloys, there can be two types of gold alloys. One is the high gold, that is the class 1. Another is the low gold or economic gold, which is class 2. High gold is again divided into 4 types: type 1, type 2, type 3, and type 4. Type 1, 2, 3 are usually used for these inlays. The low gold, which is the economic one, is varying in the gold percentage. If you look at the percentage of gold in high gold, that is class 1, it is between 75 to 85%, as against the low gold, which is 5 to 50%. Then we have another classification, which is the no gold or palladium silver, that is the class 3 alloy. Then we have base metal, which is the class 4 alloy, which is nickel cobalt with approximately 15 to 20% of chromium. And beryllium and molybdenum have been added to modify the properties. Then comes the class 5, which is the ceramic restoration. Up to here, it is there as a classification in Marzu. And since nowadays we have the composite resin that is done, which is indirect or laboratory process composite resin, I have added that as another material that is used for fabrication of inlays. Now, not all cavities are suitable for only inlay, because whatever we do, we are dependent on the extent of the caries. So there is a particular terminology which is cusp capping. So here, if you look at the picture which has been taken from stud event, if the extension from a primary groove toward the cusp clip is not more than half the distance, here, no cusp capping is required. If the extension is 1/2 to 2/3 of the distance, one may consider cusp capping. But if the extension is more than 2/3, you have to go for a cusp capping. That is why you must have seen during examination, the examiners ask for the indication. The examiners ask about the extent of the cavity. So what they actually want to know is whether you are aware of the extent of a lesion and what should be the treatment planning for the same. Now there is another term which is known as finish line. This finish line is applicable for the extracoronal restoration or the end margin. It is the junction of prepared and unprepared tooth structure with the margin of a restorative material or the planned junction of different materials. So for the extracoronal restorations, we have feather edge, knife edge, chamfer, bevel, shoulder, and bevel shoulder margins, depending on the type of material that is used to fabricate that particular type of restoration. But when we come to our intracoronal restoration, the finish line now has a different name, which is circumferential tie. So many a times you must have seen, if you want to show a pattern to your examiner, the wax pattern is taken up by the examiner. Under magnification, they try and look at something. That something is the continuity of the margins, which is known as the finish line or circumferential tie. If you begin at one particular point on the occlusal margin, there is an extension, a wax margin, a finish line, which is continuous and it comes back to the same point. So if we start here, we move, go to the proximal gingival seat and we finish here. This becomes a circumferential tie and it is one of the most important features in the inlay restoration. So for intracoronal restoration, we call these as bevels and flares. For extracoronal restorations, we call these as finish line. But we have to remember, if it is a metallic restoration, then this is the weakest link. See, every time we please emphasize and pay attention to the words that are being used. It's a cast restoration that is being mentioned. We are not talking about the acidic restorations here, because these cast restorations are, we mean it is a metallic restorations, which is either a gold alloy or a base metal alloy. So this is the finish line here, and it is the weakest link of the tooth, cement or cast joint. Now, if the margins end on enamel, we will come later how and when can the margins end on enamel. The enamel walls should fulfill the criteria of Noy. The criteria of Noy is elaborately given in Marzu. Now, it should be smooth so that the impression materials, dye materials, waxes, investment, alloy and other materials can reproduce these minute details, because we are always saying these are precision fittings or precision restorations. So whatever we prepare has to be impressed upon and then replicated in the metal by the casting process. So we cannot go wrong in any one of the steps, and all these preparations should be very definite. Now, coming to bevels and flares, these bevels should be considered as flexible extensions of a cavity that allow inclusion of surface defects, supplementary grooves, or other areas on the tooth surface. These bevels do not require excessive tooth involvement and do not sacrifice the retention and resistance form of the restoration, and they form the retention form of a cast restoration. Instead of extending the walls or overextending the walls, we can use these bevels to include all the marginal defects and structures, so that it creates an obtuse angle marginal tooth structure which becomes bulky and strong configuration of the tooth anatomy. If the bevel is created, it creates an obtuse marginal tooth structure leading to a cast substance or a cast alloy which is thick, bulky and strong. Now, this is also most amenable to burnishing of the alloy, because now it becomes a very smooth and continuous surface. They decrease the or eliminate the cement line by bringing the cast alloy close to the tooth surface. This is a bevel. This is a bevel. So instead of a 90-degree margin here, if bevel is created, this creates a very thick, dense metal margin which can again be burnished, because if we are using gold alloy, one of the important properties is it is burnishable. So whatever minor defects remain, that can be burnished and the surface defect can be closed. And these marginal bevels, they reduce the error factors, that is the space between cast restoration and the tooth. So for our restorations, we will use either long bevel, short bevel, or hollow ground bevel in case of the class 4, that is the base metal restorations, or the ceramic restorations. Now, occlusal and gingival bevels are another very characteristic features of the cast restorations, especially when we are doing gold, because these have the create an occlusal metal margin of 40 degree, making the marginal enamel to be 140 degree. And the gingival bevel is usually 0.5 to 1 millimeter wide with a 30-degree marginal metal that blends with the secondary flare. We'll look at what the secondary flare is. This is just the occlusal architecture. The ixiopulpal line angle has to be beveled. Now, there are few exceptions of these bevels. If the cusp is very steep or the preparation is very narrow, we might do away with the bevel. If the cusp inclines are very steep and the diamond instrument, when positioned at 40 degree to the external enamel surface, is parallel to the enamel wall, no bevel is indicated. This is the objective marker where the bevel will be required and where it is not required. But this is hardly the case, because in our population, we usually get teeth which are not so long and the cusp inclines are not so steep. But it is good to know that there are exceptions where the occlusal bevel is not required even for a metallic restorations. The functions of these bevels are that the weak enamel is removed. It results in a 30 to 40 degree metal that is burnishable, and a lap sliding fit is produced at the gingival margin, which is an advantage when it comes to the leakage and the fit. Primary flare is a term which is poorly understood, but it is just an extension of the wall that is created proximally. The first wall that is created in the proximal box following the isthmus area is the wall. After the wall is prepared, we have to take the wall little bit in the embrasure areas. Now, this becomes the primary flare, which is partly in dentine and partly and may be partly in enamel, but primarily it is in the dentine wall proper. So it is the conventional and basic part of a circumferential tie facially and lingually for the intracoronal preparation. It is a long bevel formed on enamel and part of dentine on facial and lingual wall. This is the primary flare. After the wall is prepared, this is the proximal box that is prepared. We just take this primary flare forms the most peripheral portion of the proximal preparation. Otherwise, a secondary flare is required. Now, after we have done the primary flare, following the wall which is formed in the proximal area, buccal or lingual, buccal or palatal, then we move on to certain conditions where the secondary flare might be required. Now, the secondary flare is something which is superimposed on the primary flare just after the primary flare. Especially, it is required in very extended buccal lingual lesions. So that the wall itself is not extended, we just slice off a little portion which is usually enamel, where the primary flare has ended in an acute margin with unsupported enamel. Once it is removed, which is superimposed on the primary flare, this becomes the secondary flare. Very, very useful for very broad contacts, malposed contacts, ovoid teeth, or surface defects of decalcifications, which are peripheral to primary flare, which get included in the process. And once we prepare this, the objective test for a correct preparation would be to run an explorer in the occlusogingival direction. If it passes freely the time, then we know that yes, our extension is correct and it is not overextended. So these are the clinical tips that you might apply when you are doing the cases. So again, coming back to what is a secondary flare, because it is difficult to understand, it is a secondary superimposed slice. That is just a cut at a correct angulation, creating an obtuse angle without sacrificing retention and resistance form, because the wall and primary flare are not disturbed at all. It is a flat plane superimposed peripheral to the primary flare, resulting in a 30 to 40 degree of marginal metal. So this is the calculation or the numerical value which is coming again and again, 30 to 40 useful for these restorations. It is prepared solely on enamel, but it sometimes may contain dentine. It may have different angulations, involvement and extent, depending on the functions and the objectives. Now, after we have done our preparation, we will come to a chart where we will discuss the depth of preparation, width of preparation, that is the configuration. But once we are done with this, the next exercise to be asked of the students is the wax pattern fabrication. So it can be again of two types: a direct wax pattern, which is created directly inside the mouth, or an indirect wax pattern fabrication, where an impression has to be taken, a die has to be prepared, and the indirect pattern is fabricated. Direct pattern, it is fast, it is difficult. Sometimes the casting and the fit, if it is not done properly, then you lose a chance. You do not have a replica there. You cannot repeat. Whereas if it is an indirect pattern, If something goes wrong, we can come back again, revisit that particular inlay preparation because we have a die and we can recreate and replicate whatever we have done. Now coming to the specific indications for a metallic inlay. This is the general indication and contraindication. Most of the ceramic or composite inlays also share the same indications and contraindications, barring few exceptions. So, coming to the specific indications, it is an alternative to amalgam and composite when higher strength of a casting alloy is required because there is no layering. It is a single solid metal without any voids. So, the yield strength, the mechanical properties are much better. The cavity width does not exceed one-third of the intercuspal distance. The teeth have minimal or no occlusal facets. There is a wider proximal damage requiring indirect procedure for superior contact and contour. The tooth is not an abutment for fixed or removable processes. The occlusion is not projected to be changed by the restorative procedure. Strong and self-reliant cusps remain. This is one of the prerequisites that the buccal and lingual, buccal and palatal cusps are strong, self-reliant and have bulk, and teeth with recurrent restoration failures, which is direct in nature, is of course an indication for the inlay, which is metal based, or as I said, generally all inlays, barring few exceptions for ceramic and composite restorations. The contraindications would be high caries index, poor plaque control, adolescence, MOD restorations, and poor dentinal support requiring a very wide preparation. These are the conditions where the cusp capping or further or any other kind of restoration like onlays or full crowns are required. Coming to the advantages, of course, the superior mechanical properties, the longevity. For a gold inlay, which is actually a gold standard, the average longevity is 35 to 40 years. There is no discoloration from corrosion, and it is the least complex of cast restoration because gold is a material which is easily cast. The casting process is very easy, whereas the casting of base metal is little difficult because of the inherent properties, mechanical properties of the base metal. They are less conservative than amalgam restorations. It may display metal, and the gingival extension is beyond the ideal. There is a wedging effect because it tries to split the tooth apart. Of course, it is technically demanding and it is very, very economically, it is very pricey. And nowadays, with the prices of gold and silver skyrocketing, it is nearly an impossible situation to prepare anything out of gold. But there is one problem. Many a times we say that there is a demand for aesthetic restorations. Of course, by aesthetic, we mean tooth colored restoration. But gold is such a material, even though the color is yellow, still, when it is placed in the mouth, it retains that same color and shine and sheen. So, once it is placed in the mouth, if the color is acceptable, the aesthetics of the gold restoration itself is maintained throughout life or as long as the restoration remains in the mouth. Coming to the specific indications, contraindications, advantages, and disadvantages of the ceramic inlays. See, the first indication is small to moderate caries that might raise many eyebrows. That why for a small restoration we would do an inlay restoration. Well, it is not only about the size, it is about the longevity. If a patient is demanding a restoration which has the longest life, then of course inlay is the solution. Inlay is the answer instead of any direct restoration. The demand for aesthetics is also there. Low caries rate is mandatory, or sometimes a large carious or traumatic lesion with undermined enamel, but again intact and lingual enamel is required. It is also an indication. Teeth where it's difficult to develop retention form may be an indication for the ceramic inlay as against gold alloy inlay because we are depending on the bonding for retention. And teeth with recurrent restoration failure is, of course, an indication for any kind of inlay. Contraindications include high caries index, poor plaque control, bruxism, which is a strict no-no, groove function occlusion, strict no-no, inability to maintain a dry feel because it is extremely technique sensitive. If we cannot maintain a dry feel, if it is very subgingival and the saliva control is not good, then we will not be able to do a proper bonding and it is bound to fail. The advantages include superior aesthetics, it is conservative, it is durable, and it has a disadvantages of abrating the opposing tooth. The occlusion is very difficult to adjust. It is a very hard material, it is brittle also. So if until the time it is unbonded, it is extremely brittle. So try-in is a very huge difficulty for the ceramic restorations. The moment you go for a try-in, it might fracture. But the moment it is bonded, supported by the cement underneath, the hardness increases, the brittleness goes down. So occlusion is very difficult to adjust. There might be wear of luting or bonding agent, especially at the margins, and there may be micro fractures of the bonding or luting agent. Of course, it is expensive, less expensive than gold. The long-term success is still unknown compared to gold inlay restorations, and the strength of unbonded restorations is less, as I said, because unbonded restoration is extremely fragile. Coming to the composite resin inlays, the conservative cavity preparations that have an isthmus of less than one-third the cuspal distance may be an indication. Again, repeated failure of a restoration and patient desires tooth-colored restoration. Of course, this is an indication. As a replacement of existing metallic restoration for aesthetic reasons and with a high longevity demand, this can be an indication. And aesthetic restoration for teeth in patients who have a diagnosis of bruxism or clenching and exhibit mild to moderate wear of the opposing dentition. Here, definitely indirect composite inlays are an indication above the ceramic inlays. The contraindications include very heavy occlusal forces because the strength is still less compared to the bonded ceramics and the gold or base metal alloys. High caries index, we should not. Poor plaque control, heavy bruxer, heavy groove function, inability to maintain a dry field because we will not be able to do a proper justice to the bonding technique, and very deep subgingival preparations we might not be able to isolate properly. The advantages are it offers good aesthetics. There is a better control of the contact area because it is prepared outside. There is excellent marginal adaptation because it can be checked. There is repairability of the material, but the disadvantages also include the higher cost of the setup, multiple visits. It is repairable, but it is difficult to repair once it has been placed. It is technique sensitive. There is less wear than the ceramics on the opposing dentition and more wear of the material itself, and there is a potential for discoloration. Now coming to the examination do's and don'ts with this background. This was a background of what are the possibilities when the task is inlay, which is specifically class 2 inlay. We have discussed why, and the materials have been discussed. The methods of fabrication have been discussed. Now, what should we do for examinations and what should we take care about not doing? Firstly, we should have very good X-ray. Both IOP and biting are advisable, and the student must be very well versed with the dimensions of that particular X-ray, depth of the cavity, dimension of the cavity, and the X-ray itself should be very good, so that the adjacent teeth just in front of the tooth in question and tooth just behind the tooth in question are also visible. Occlusally, at least 5 millimeter and peripically at least 5 millimeter is visible in the same extent. Good articulated cast without bubbles, it should be there ready. The case history with pictures, diagnosis, and treatment planning should be ready. This is also because it reduces the student's stress on the day of examination. Whenever a question is asked, at least if the student has prepared the case history with pictures, diagnosis, treatment planning, he or she must have gone through the indication, contraindication, the case selection, everything. So it is there in the student's mind instead of trying to recall from memory and getting confused. Thorough oral prophylaxis is mandatory and it is best done at least a week prior to it so that the patient is also counseled. There is no gingival bleeding either during preparation or during the impression procedure. And plan the cavity design before starting the case. That is very important. If the indication is there, it is there. Never try to create an indication that leads to a lot of trouble. Consider the caries extension, anatomy of the tooth, occlusal and proximal relationship, contour of the tooth that needs to be re-established or improved. Because The examiner might ask you to do a gold restoration, base metal restoration, aesthetic restoration. So the specific indications and contraindications are required. What kind of bevel, why it is required, we will come to a few slides on that again. But these are all mandatory. That is why the relationships and the extent of the tooth, the cavity is very much required. Now, anesthesia of the operating field is a prerequisite to good dentistry because it will eliminate pain, it will decrease the salivation, and the patient is less sensitive to stimulation of oral tissue, and this increases the operator's efficiency. So, students might consider using anesthesia. And of course, in today's time, magnification will definitely enhance the work quality and it will have a good impression, it will leave a very good impression on the examiners as well. Now, any case can be selected provided it comes under the indications. But it is very important or advisable to select only straightforward cases because of the simple fact that during examination, all these stresses, which are extra stresses generated by complexity of case, should be reduced. So very simple, straightforward, but indicated cases should be taken. So worn out dentition with minimal or no occlusal facets, this should be taken care of. Teeth without opposing tooth in occlusion or absence of adjacent tooth. Strict no-no. Very young teeth with large pulp chamber and high pulp horns, you run the risk of damaging the pulp and then you will invite a lot of extra steps and questions. Tooth with gingival inflammation, since it may induce bleeding during prep and the impression making. Deep dentinal caries in close proximity to the pulp, try and avoid. All these are readable on a good X-ray. Subgingival caries best avoided because if you are doing an aesthetic restoration, even though only a pattern is required, you might be asked questions. Extensive caries with broad contacts on mesial surface of upper first molar, if it falls in the smile zone, especially for a gold-based restoration or metal-based restoration, try and avoid. Adjacent teeth with proximal caries, unless and until it is already restored, you should not take that particular case. And teeth with recurrent restoration failures, you should not take because patient might be uncooperative, too many questions will be invited, and ultimately you need a peace of mind and a case that is most conducive for your examination purpose. As I said, that you should not create the indication should be there, and rest of these factors should be considered before the case selection, and all the cases should pass through the eyes of your internal examiners before they are seated on the dental chair on the day of examination. Now coming to a few clinical cases. So this is a good indication because you see the proximal extent. So here you can justify. All these proximal extents can be justified. Most of you are bringing cases which are very small cavities, and then the examiner will ask you why a direct restoration cannot be done because this is conducive. Even for a direct restoration, it is not huge. It will be retentive. If you give a proper retention form with the bonded techniques, everything is possible. So why you need a definite indirect restoration? So recurrent failure, broad contact, huge, that is more than 1/4, that is at least 1/4 of the intercuspal distance. By intercuspal, we do not mean the isthmus area, it is the cusp tip, distance between the cusp tip, it is more than that. All these cases definitely fall under the ambit of the cast restorations. Now coming to this part, the tooth preparation for different materials. Now see, this is a classification where class 1, class 2, class 3, class 4 and class 5 materials have been discussed. Additionally, composite resin has been discussed. Now width, depth, isthmus, line angle, point angle, pivot surface angle, bevels, taper and clearance with adjacent teeth. These are the different headings under which we should be prepared with our cavity preparation. So if you are doing a high gold restoration, it is 1/3 the intercuspal distance. But if it is a no gold or base metal alloy, it is wider. If it is ceramic, it is even wider. For composite resin, it is usually 1.5 to 2 millimeter. Coming to the depth, it is 1 to 1.5 millimeter within DEJ. For No gold, it is more. And for ceramic, it is more than 1 to 1.5 millimeter. For composite resin, it is 1.5 to 2 millimeter. Coming to the isthmus is one-third the intercuspal distance. For ceramics, it is 2 millimeters, and for composite resins, it is just less than 2 millimeters. The line angle for all metallic restorations, these are very definite, except for the no gold or the base metal where it is rounded because of the castability. Because as I said, the castability of these materials is less as against the high gold alloys. For ceramic, it is extremely rounded because we do not want any stress concentration. For composite, it is just rounded. For the bevels and flares, for the high gold, we prefer the short bevel. We have discussed bevel previously. For the no gold or the base metal, we prefer hollow ground. For the ceramics, either it is an exaggerated hollow ground or no bevel, or we can give a shoulder margin. For composite resin, we do not want a bevel. The taper is usually 2 to 5 degree per wall for the high gold. For the no gold or base metals, it has a less taper. For ceramics, it is minimal or even 10 to 12 degree taper. So the taper is minimal, it's quite divergent. For composite, it is slightly less divergent. The clearance that is to be established with the adjacent tooth is 0.2 to 0.5 millimeter up to the base metal alloys. For ceramics and composite resins, it is 0.5 millimeter. Coming to the procedure, for the metallic restorations, we primarily use 271, 169 and 169L and 8865 or 8862 flame. For the composites or ceramics, we use the ceramic inlay preparation kit, which is not so readily available. So we could try for any tapered diamond which has a rounded tip. This is the rounded tip so that the internal line angles are also rounded. So for cast gold inlay, occlusal bevels are necessary. For ceramic inlay, it is hollow ground. For composites, they are best avoided. Gingival bevels are needed to achieve the minimize the marginal gap and a lap sliding fit. For ceramic inlay, it is not required, and composite is not required. 2 to 5 degrees cervico-occlusal divergence, 6 to 7, even up to 10 degrees acceptable. For composite, it is 6 to 10 degree of cervico-occlusal divergence. Now, the marginal adaptation for cast gold inlay, it is dependent on a very good adaptation. That is why the gold inlays are best. They can be burnished even after they are cast. Now, usually we are looking at a film thickness of 20 to 25 millimeter for the intervening cement. So, for ceramic inlay, it is only the addition. For composite inlay, the addition is relied upon, whereas for cast gold inlay, it is the friction which is relied upon along with the cement. But majorly it is the parallelism, but we cannot give a true parallelism because it will be very difficult to move the restoration in and out and do all the processing. That is why 2 to 5 degree of a practical divergence is given. The pulpal floor is flat and perpendicular to the long axis, whereas in case of ceramic inlay, since we need a uniform depth, if the cavity preparation is dipped in the middle, it gives a good bulk even in the central groove area. We will see this in a picture. For composite inlay, a flat pulpal floor is recommended. The internal line angles for metallic restorations are very well defined except for base metal where it is slightly rounded. For ceramic, it is rounded, and composite inlay, it is also rounded. So this is the difference in the tooth preparation, the configuration we have seen in the previous slide. So this is the picture that I was talking about. If you look at this particular picture, if a flat pulpal floor is given for a ceramic restoration, look at the bulk of the ceramic material that happens here as against if the cavity preparation or the tooth preparation is slightly dipped where the central groove will be running. This gives a adequate bulk of the ceramic material. After the tooth preparation is done, you have to move on to the impression procedure. And the first in the impression procedure is gingival retraction. You should consider gingival retraction even during preparation of the proximal box. This will reduce unnecessary stress to the gingival area. The bleeding will be minimized, the gingival tissues will be spared, and you will get a good margin when you do the impression. So the retraction cord is placed to displace the gingiva away from the preparation margin to control moisture due to gingival hemorrhage and the gingival clavicular fluid. Usually it is 1 millimeter beyond the gingival width that it is placed, and it should be less than 10 to 15 minutes so that the gingival ischemia is prevented. You should not overstay, make the gingival cord there overstay. And you must remove the cord before making an impression. That is mandatory. Otherwise, the impression will not be recorded. We will not get the finer details. Impression procedure may be direct or indirect, and direct method may be open or closed. So direct method is where you place the wax directly inside the tooth cavity, carve it over there, ask the patient to bite, get the occlusion, apply the screw former, take it out, and you can go for the investment. Whereas the indirect method, where an impression is recorded, it is usually advisable to go for the additional silicone materials, but please remember, do not use the latex gloves because it will inhibit the setting of your additional silicone, or have your assistant mix the material for you. The tray is loaded, and there can be two methods. It can be a single step and it can be two-step method. Single step method is faster, but what happens is, due to the difference in viscosity of the putty or heavy body and the light body material which are put together, it might so happen that from inside the cavity or where the finer details are required, the material does not flow at all, or it flows out of those areas. That is why a double step material or two-step technique is more advisable, where you take the impression with the heavier body or the putty, place a kind of separator, and then remove it, and with a light body or wash impression, record the impression of the particular or prepared tooth surface. Remember, when you have to remove the impression, it should be, the vacuum seal should be broken and it should be removed with a single jerk instead of shaking and tweaking it for a longer time, because it distorts the, or it might distort the impression, and then you will not have a correct casting. Also, this should be washed under running tap water. It should be disinfected with 10% glutaraldehyde. Wait for 10 to 20 minutes before you pour the impression. Do the dye preparation. After the dye preparation is done, you will do the wax pattern fabrication. Depending on what instructions is given by the examiners, they might want to see both direct pattern and indirect pattern. So depending on that, you have to have all the armamentarium and materials ready. So we have this ADA specification, 4 for the wax. So type 1 wax and type 2 wax, that is for the direct pattern and indirect pattern. And we have to have all the armamentarium. This is the basic composition of the inlay wax. The difference is in the hardness and the flow for the wax pattern, wax that is to be used for direct pattern and that for the indirect pattern. Now we have a set of instruments which is known as PKT instrument, which is a set of 5 instruments. So the first is, what we do is, during the preparation, we do the positioning of the functional and functional cusps. Then we do elimination of voids in the occlusal surface, that is the finer details are given with number 2. Smoothing of the grooves is done, that is the anatomy is formed. The smoothing of the axial surfaces. The 4th PKT instrument is the universal carver with which we can do, and the last of the PKT 5 is the one that is used for preparing the ridges. So this is the instrument that we use, and after we have used it, we do a polishing with the silk cloth, place the screw former. Now coming to the screw former, please do not use the term screw, because screw is screw once it is cast. Before that, it is a screw former. So it is a channel through which the molten metal is flowing. The type of screw former may be resin, wax, or metal. It can be smooth or cylindrical. Anything is acceptable, but the diameter of the screw has to be equal to the thickest portion of the wax pattern, because the melt velocity of the casting metal will be directly proportional to the diameter. So usually 8 to 18 gauge screw is required, and the length of the screw is very important. If you look at this diagram, which is so classically given in Skinner Phillips, so the upper end of the wax pattern is within 6 millimeter or 1/4 inch of the open end of the casting ring, which is for gypsum bonded if it is gold, and within 3 to 4 millimeters for higher strength phosphate bonded investment, that is if it is a base metal. The number of screws depend on the configuration pattern. Usually for a small inlay, only one screw is sufficient. It is located at the bulkiest portion with a 45-degree flaring for ease of removal and placement. The wax pattern and the screw joint should be extremely smooth and uninterrupted for the smooth flow of the metal, and it should be flared. A reservoir is to be placed 1 to 2 millimeter from the pattern to prevent the localized shrinkage porosity, and it is not required for the pressable ceramics. Venting is required to escape for the escape of gases, and it is when it is not proportional to the speed at which the melt of the molten metal enters. And the wax pattern has to be treated with the surface active agents so that the surface tension is reduced and the investment material can easily and nicely adapt to the wax pattern, because whenever we are forming the mold, whatever mold is formed, the casting reproduces the same. Then we go for investing. From this step onwards, it is probably not required for you if the examiners demand that you have to show till the pattern only. Now, when you go and show your pattern, it should be placed on a damp cotton, because wax is a very, very sensitive material. It is the toughest material to handle, and since it undergoes dimensional changes in relation to the thermal changes, even the humidity and the ambient temperature matters. So whenever you go, it is placed on a dampened dish on a moist cotton, covered with a moist cotton. Always use a pair of tweezers and magnification glasses so that it can be examined properly and held properly by the examiner. So we are not going into these procedures. Of course, if somebody is going for a ceramic inlay and the fabrication is asked, or for the composite resin inlay, you must be ready with the answers of the fabrication methods, especially for indirect resins, which is the oven, and for the ceramics, which can be chairside CAD/CAM or 3D printing. Now, these are just a few clinical cases just to show the indications that have been done in the department. This is a indirect composite restoration and an indirect ceramic restoration. All these cases are done by the postgraduate trainees of the department under the guidance of the teachers. Now coming to few probable questions for chair side. Firstly, be prepared for the diagnosis, indications, contraindication, advantage, disadvantage of the proposed type of inlay, because examiner will ask you what kind of inlay you will give, irrespective of what is written in the DCI mandate. The examiner can ask, these are the options. So the more options you have, the more difficult it is. So that is why I said there are certain specific indications and there are some general indications. Now, always patient's desire should be taken into consideration. If patient has the mild longevity and aesthetic, then of course you have ceramics and composites, provided there's an indication. So if it is a wider cavity, proximal margin is very wide, recurrent failure, still patient demands an aesthetic restoration and a long-lasting restoration, you can go for a ceramic restoration if the patient doesn't have occlusion issues. So these should be the answers that you should be ready with. That is why case selection should be done well ahead of time. And you should have at least 3 cases for every clinical examination task. Then the treatment planning of the case, what have you planned, why have you planned, alternate treatment options if any, How do you plan to manage the patient's pain and anxiety? The instruments, materials, and techniques for cavity preparation and processing. Now, this processing will include both the casting and the fabrication, that is, the chair side, CAD/CAM, 3D printing, and indirect composites. Cavity design justification, why the configuration is required, what are the steps of the indirect restoration, because you will have to show Tilia wax pattern, and try and finishing, polishing, luting, bonding can be questions, even though you might not be asked to do it in the for the practical examination. For the long questions, if you are going to appear for your theory paper, casting defects and processing defects, gingival tissue management, the forces that act on a class 2 inlay, the different indirect restorations for inlay for posterior teeth, advantages, disadvantages of each, enumerate the retention and resistance forms to be used when the mesiolingual cusp is missing in a vital mandibular first molar. So here you must consider which is a visible zone, which is a non-visible zone, which is the tooth in question. All these are hidden in the question itself. Inlay wax, of course, is a huge chapter. The dye materials, marginal integrity of a class 2 inlay, ceramic inlay, and the fabrication procedures, design and feature of inlay cavities for different restorative materials, as we have discussed. Previously, it was easy, only the types of gold, base metal, and ceramic. Now we have lots of ceramic, we have the inert composites and the pure gold alloy. It is reducing because of the cost. So you have to be abreast with the current consensus and current demands. What is the recommended armamentarium and what sequence should a mandibular molar be prepared for a class 2 inlay with gold alloy or acetic materials? Question can be anything. So this is the chart that has been prepared, which is a typical traffic lights chart for the assessment parameters. Green is very good, yellow is moderate, red is bad. This is a comparison between cast gold, ceramic, and composite when longevity, marginal integrity, micro leakage, fracture, fit of restoration, anatomic contour, color stability, radio opacity, plaque accumulation, and bonding are to be considered. So this is a composite chart. The reference is from the reference list that is given here. So the take home message at the end of this session: thanks to your patience, read books, do adequate and varied clinical cases, and do the laboratory or processing work on your own, which is most important. Otherwise, the words will not make any sense to you. So thank you again for this opportunity.